Hi, my name is Siali Foliaki. I'm a consultant psychiatrist here at Capri Hospital. I am the medical director, and what I'd like to do in the following podcast is give you some relevant points around certain medical and mental health conditions that I think would be important for us to consider in our ongoing delivery of services to our patients in primary care. I completed my qualifications with the Royal College of Australian and New Zealand Psychiatrists in 2006. I was trained as a general psychiatrist, and one of my interest areas was service development in primary care. More recently, I retrained in 2013 as a child psychiatrist because I recognised that a lot of adult pathology, psychopathology, was a result of challenges with mental health problems in childhood. And I think now, as a fully completed and accredited child psychiatrist, I feel that oversight of developmental and adult problems has given me a unique perspective on what the challenges are in terms of service provision for all age groups when it comes to mental health disorders. As a result of the experiences that I've had in the mental health sector, what I would like to do is to give 10 relevant points that are important for general practitioners in their delivery of mental health services. The first point that I'd like to focus on is the increased prevalence of mental health disorders in our community. One of the really fortunate things that I was involved in was the New Zealand Mental Health Survey, which is the results of which were published in 2006. But what it showed, and a lot of GPs know this fact, that the prevalence of mental health disorders is very high. We know that 1 in 4 New Zealanders will suffer from a mental disorder over the course of their lifetime. We also know that somewhere between 30 and 40% of all GP consultations have a significant psychological component. So what does this mean? It means that general practitioners, we have to be, as working alongside us as psychiatrists and mental health providers, have to be much more conscious, I guess, that the person walking into their consultation room may have a significant psychological problem, and I guess screening for and trying to uncover what those problems are is a really important consideration. My second point is that we know that the prevalence of mental health disorders is increasing in the population. As doctors, and particularly general practitioners, we're part of that population. So I just want to make a comment and a reminder to all of us that our own personal well-being is really important. So what do we know? We know that actually doctors' rates of alcohol dependency were actually higher than the general population before in the 1970s, 1980s. But over time, the health of doctors, in particular our problems with alcohol, have actually decreased. We know that now that there's a slight decrease in terms of alcohol dependency amongst doctors compared to the general population, but we know it's still significant. The international studies show that opioid dependency amongst doctors is still very high. It's in the 10 to 12% range. So as a group of colleagues, we have to be very aware of the potential for us to develop addiction problems. Alongside that, we know that our rates of stress-related illnesses, which lead to depression and high levels of anxiety, are probably higher than the general population. So monitoring our own well-being is a really, really important consideration. What we've found, thanks Liz. Cheers. What we've found is that self-reporting when it comes to particularly addiction issues is just so much better received by the medical council. So that would be our recommendation, is to be aware of colleagues, and if you have a problem yourself, is to attempt to self-refer rather than the medical council have to get involved when these problems come to the surface anyway. And so what does it mean for you as a medical practitioner? There's really good support out here, and both evidentially in terms of our own personal experiences and the research that goes into the area, that medical practitioners, once they address an addiction problem or mental health problem, tend to do really well. What the research shows is that total alcohol consumption has levelled off actually in New Zealand society, and it actually has slightly decreased. But there are two specific populations where alcohol dependency and hazardous alcohol usage has actually increased. and that is with women and with our older age group. And so I think that, as a group, if general practitioners could be just more consciously aware when they've got a woman coming through for a consultation, or for elderly people, it'd be great if we could just ask a couple of screening questions around alcohol and the use of alcohol, because these are two unique populations that I think that we've just got to focus a little bit more on. For those of you that may not be aware of the Ministry of Health Mataraki guidelines, these guidelines essentially provide a really good resource if you're undertaking alcohol detox in the home situation. Particularly if the detox is, it's more in the mild range, then those guidelines are very, very helpful. They are free, and you can get a copy sent out to you, or you can find it online at the Ministry of Health website. The fourth point that I'd like to make is around the use of prescription drugs, which kind of leads on from illicit drug use and alcohol. Recently we had an experience here at Capri Hospital where we had a young man referred from a psychiatric institution outside of Auckland, transferred to our care. And one of the interesting things that we only found out later after his admission was that on the drive to Auckland he stopped and he drank large amounts of a stimulant drink. It was V, I think, and had a large amount of coffee. And during the admission process we found that his heart rate was elevated, he was tachycardic, his blood pressure was elevated, he was flustered, sweaty. And so we felt that he had significant withdrawal symptoms and ended up putting him on quite a significant amount of diazepam, only to find out later that actually he didn't have significant withdrawal symptoms and his level of anxiety wasn't as high as we initially felt. And so what am I saying? I'm saying that often in the community settings, patients are prepared to, or they're getting more sophisticated is the way that I would put it, in terms of their drug-seeking behaviours. And we also found out that a lot of the symptoms of anxiety, and particularly panic disorder, that the patient, the client, was well versed in. So what we're finding is a new trend in psychiatry is patients coming, having access to the internet, very, very clued up about what the symptoms of anxiety are, and basically causing us as medical practitioners to prescribe significantly larger doses of prescription drugs that have an addictive element that actually isn't prescribed accurately because patients are getting more sophisticated in their ability to feign symptoms. This leads me on to my fifth point, the benzodiazepines. We all know how useful the benzodiazepines are in acute stress, distress, anxiety, and particularly withdrawal from either benzos or alcohol. The challenge we have is often, when do we pull the reins in on the benzodiazepines? The real danger that we have, and our clinical experience here at Capri, is that the diazepam itself, it erodes a person's willpower. It has real effects on people's short-term and long-term memory. That's not just intellectual memory, that's emotional memory as well. And therefore, the very thing that we're striving to treat, which is to manage stress, manage distress, anxiety, and withdrawal, is that if we persist with the use of benzodiazepines, we erode the person's ability to actually have the mental fortitude to deal with the life stresses that they're experiencing. So we're finding that often a lot of our patients are still managing to access significant amounts of diazepam, and our experience is that general practitioners are still prepared to let a patient walk out of their surgery with 30, 60, 95 milligram tablets of diazepam. And I'd like all of us to ask the question, if we're going to start a medication like diazepam, we should ask the question, when are we going to stop it? And what structures do we put in place to stop somebody from needing to use a benzodiazepine? So just that thought process, I think, would be really, really helpful. And just to add finally about the negative impacts of benzodiazepines in terms of treatment of anxiety or stress conditions or withdrawal from alcohol, it's the policy of our hospital and the community alcohol and drug services, for example, that it's not until people get under at least 20 milligrams of diazepam per day that we can really do effective treatment psychologically, and involvement in the groups that we run necessitates sort of lower doses of benzodiazepines. I guess a talk of this nature would not be complete unless we discussed depression. So I think all of us as a medical body, I think everybody's become very aware of the high prevalence of depression, and I think across the board the treatment of depression from primary care right through to sort of tertiary care, it's become more effective. I guess I'd like to make the point during this discussion is I still think that we are not picking up the adolescent population and their problems with depression. So what does the research show? The research shows that the greatest morbidity in terms of this particular diagnosis is carried by the 16 to 24 year olds. Yet the evidence is that the medical profession still isn't picking up the number of kids that you would expect considering the high prevalence and the high morbidity that's involved with depression in this particular age group. So what am I saying? I'm saying that I think as a medical fraternity, we have to get better at recognizing depression in the adolescent population, most importantly. The key indicators for adolescent depression is the reactive nature. And so even if an adolescent comes through and you're seeing them for a medical problem, they can often present as if there isn't a depression present because of the reactive nature of depression in adolescents. And I think therefore it's more important as a group of medical practitioners that we at least ask the question of our adolescent population. And what do I mean by reactivity? What I mean by that is that an adolescent who's feeling very vulnerable and psychologically fragile, they can present like they're well, but a phone call or a text from a girlfriend that is not received well or doesn't contain good news can lead that adolescent to have quite a marked depressive reaction. The seventh point that I'd like to make is the challenge of dealing with comorbid problems. What I mean by this is that often alcohol and drug addiction problems coexist with major mental health problems. Firstly, I think often the comorbid problem is missed. So often we pick up on an alcohol-related problem and we miss the depression or the anxiety or the trauma. And often we pick up on a depression and no real focus on the addiction component. So what does that mean? The evidence shows that if there's a comorbid problem, their treatment resistance is higher, treatment effectiveness is lower, and therefore effective treatment for both components is really critical. And it's something that I guess is manageable in primary care if you feel pretty confident in your skills, but often requires more expert involvement. Comorbid conditions are extraordinarily challenging. And so often when you're trying to reduce substances that people have been using to sometimes self-medicate and maintain a non-depressed state or treating anxiety, when you try to address that, the depression and anxiety worsens. And so one of the unique experiences that we've had is the quality of our working relationship with the primary care, with the GP and the GP team really becomes particularly important for coexisting problems, because it's going to be the structured care over a longer period of time that becomes really important. The eighth point that I'd like to make is the growing prevalence of eating disorders in our community and how often they're presenting into primary care, and perhaps the need for us to be a little bit more focused on this particular diagnosis. Professor Gavin Andrews, in a research that he's done in Australia, is basically pointing to the fact that there are 2 young women in each Australian classroom that meet criteria for a diagnosis of anorexia nervosa. So what does that mean for New Zealand? I think we're a little bit behind the Australians, but we have seen a continued climb in the rates of young women that are suffering from what is a pretty difficult and can be a life-changing condition. And so just a growing awareness, perhaps when we're seeing young women. It's a very difficult issue to raise with young women because they don't like it to be raised. But by being really conscious of this particular disorder and its growing prevalence in our community, and perhaps working with parents alongside the young person when they're presenting, and it's noticeable that perhaps they're slightly underweight, and that there might be this eating disorder sort of just sitting below the surface. In summary, I'm very conscious of the fact that it's a busy place, primary care. Sessions are short and people are in or out for a specific problem. And attempting to ask about these conditions that I've mentioned can be extremely challenging and often difficult to do in practice. But I guess that's what these educational podcasts are all about, is just trying to keep certain things in the forefront of our minds so that we can act on them when we see an opportunity. And love to thank you all for listening to what I've had to say, and hope it's useful at some level.